Good afternoon, and thank you for joining. I am Sherilyn Francis,
Thank you.
and on behalf of the South Carolina Tobacco Free Collaborative, we welcome you to part 5 of our Tobacco Cessation and Health Equity webinar series. The mission of the South Carolina Tobacco Free Collaborative is to eliminate the toll of tobacco use by providing leadership, guidance, and resources to state and local partners. The SCTFC's partnerships with coalitions are utilized to address local tobacco issues and to promote positive public health policies at the community level. The core principles of the South Carolina Tobacco Free Collaborative are to provide leadership in the development of state, county, and local tobacco policies, to facilitate meetings with interested organizations and communities, to promote opportunities for stakeholders to examine research, trends, legislative issues, concerns, and ideas while simultaneously generating solutions, and to promote and support advocacy for tobacco-safe communities at the regional, state, and national levels. I now present to you today's webinar entitled Tobacco Control in Active Duty Military and Veteran Populations, presented by Dr. Ellen Erbst, Associate Clinical Professor, University of California, San Francisco, and Associate Chief Addiction Recovery Treatment Services, San Francisco, VA. In compliance with ACCME guidelines, Dr. Erbst has no financial or other relationships with the manufacturer of any commercial service discussed in this educational activity. The objectives for today's webinar are to characterize tobacco use among active duty military personnel and veterans, to evaluate tobacco-related health disparities faced by military personnel, to appraise methods of tobacco use treatment within the Veteran Affairs, and to assess the future direction of tobacco control and tobacco treatment within the VA and among external partners. And now, Dr. Erbst.
Thank you so much for the introduction. It is such a privilege to join you today. I'm really happy to see such a strong interest in tobacco control measures for active duty military and veterans. It really means a lot to us, those of us who work with this population. So I look forward to going through the talk and then also hearing from all of you with some questions. So to begin with, an overview. I think this group probably knows, but the overall in the United States, we have had great success in tobacco cessation. So over the past 50 years, there has been an incremental decline, particularly in smoking rates in the US population. Most recent rates from the CDC are approximately 15.1%. However, unfortunately, certain groups lag behind. And per CDC and other groups, the decline that we've enjoyed in the general population has not reached certain high-risk groups. And that includes active duty military and veterans, as well as individuals with mental health conditions. And as you can imagine, there's a lot of overlap between these two. So particularly, my work is primarily focused in the veteran community, and we have a lot of veterans who have experienced co-occurring mental health conditions, which can only place them at greater risk of difficulty quitting smoking. Another consideration is that smoking is higher in veterans who were previously deployed to combat. So given that we are currently in multiple ongoing conflicts, this is of particular interest when we think about young adults and their risk of returning from deployment with a tobacco use disorder. And as I mentioned before, individuals with mental health conditions are at elevated risk. So this includes veterans with PTSD, depression, anxiety, schizophrenia, bipolar disorder, and a number of other mental health conditions. So to consider the impact of tobacco use in military and veterans, the economic impact is staggering. As you can see, based on these numbers, it's estimated that annually 2.7 billion in healthcare costs in the VA can be attributed to tobacco use. And the DoD also estimates that there's 1.6 billion annually. And again, I think with this audience, we know that there are numerous adverse effects that go well beyond the scope of this lecture, but just a few to consider with military. Um, Tobacco use really adversely impacts military readiness, and I think this is something that fortunately leadership in the Department of Defense has noticed recently. There's an increased risk of injury, impaired wound healing. There is a higher rate of mental health disorders, and there have been several recent studies that have identified an elevated risk of suicide co-occurring with tobacco use. That association needs to be examined further, but it's quite concerning. Obviously, given that tobacco is expensive, there's greater financial strain. There are social impacts of tobacco as well in families of service members, and higher morbidity and mortality. So all the more reason to really boost efforts to try to help our military and veterans quit. And as this group probably knows, there's at least an estimated decade of life lost in individuals who smoke versus those who don't. So this is a slide that was prepared by the Truth Initiative, and it's based on Department of Defense data. And what's really important to see here is that smoking prevalence among troops varies by age and service. And the age isn't depicted here, but it's been noted that in this 2011 report from the Department of Defense that young enlistees smoke at a higher rate than commissioned officers. It's also been observed that certain branches of the military are associated with higher rates of tobacco use and cigarette use specifically. So for example, Marines have the highest rate of smoking at 30.8%. And that compares with the Air Force, which you can see is kind of, in this sample at least, similar to the general population. It's not too much higher. Overall, among all service members, the DoD study in 2011 found that 24% of active duty military personnel reported smoking cigarettes compared to, at that time, 19% of civilians. What also concerns me is that 38% of current military smokers initiated tobacco use after enlisting. So there is something that occurs during military service that is associated with an increased risk of tobacco use. We can get into that as well. Because everyone is very interested in e-cigarette use, I did review the literature, and unfortunately there's very little available, at least in active duty. One study reported a 5% prevalence in U.S. Air Force recruits of e-cigarette use versus there's a lower prevalence, is my understanding, in the community, although I'd have to verify that. But we do need more investigation. So among veterans, this is data from the CDC National Survey on Drug Use and Health, which examined past 30 days of tobacco use among veterans from 2010 to 2015. And 29.2% of veterans reported current use of any tobacco product. This did not include e-cigarettes, but it included cigarettes, cigars, smokeless tobacco, roll your own tobacco, and pipes. And concerningly, 7% reported use of 2 or more tobacco products. And this is something we do see a lot in our clinics. We do see that veterans may use both chewing tobacco and cigarettes, for example. I can get into the specific risk factors in the next slide. So this is a familiar theme. It's probably consistent with what you've heard in some of the other lectures, is that there are certain risk factors that place someone at greater risk. So overall, the population may not be at substantially higher risk of tobacco use, but if you look at certain high-risk populations, there's a substantially greater risk. So for example, again, age is a factor. So ages 18 to 25 years reported a 56.8% prevalence of recent past 30 days tobacco use as compared with the overall sample, which was 29.2. Hispanic veterans were at higher risk. Individuals with less than a high school diploma, additional risk factor, low income, and whether it be defined as a family income less than $20,000 a year or poverty level, individuals who are unmarried, and individuals with mental health conditions and or self-report of serious psychological distress were at higher risk. And finally, uninsured veterans were at higher risk, which is not surprising to me when I think about the quality of the services we deliver at the VA for tobacco cessation, and we're going to get into that as well. So this is again from the same study. It's the National Survey of Drug Use and Health, and you can see, particularly in certain age groups, the veteran community is exceeding the non-veteran community in non-cigarette tobacco use. So if you look at ages 18 to 25, the male, that population of veterans is using a range of other non-cigarette tobacco products, such as smokeless tobacco, for example. Same applies for actually ages 26 to 34, 35 to 49. So this is really the post 9/11 group of service members and veterans who are likely at greater risk of using both cigarettes but also non-cigarette tobacco products. And interestingly, as you look at the older population, ages over 50 years, male, you'll see that that actually veterans are using non-cigarette tobacco at lower rates than the non-veterans, which is interesting. And the authors did not have the opportunity to review the causes of that, but I wonder if it may have something to do with the VA and the services delivered. When you think about some of the health disparities that active duty military and veterans face, we began to discuss some of that, but one thing to think about that's quite obvious especially to those of us who work with service members and veterans, is that the stress of deployment and military service itself places one at elevated risk of initiation of tobacco use. So it's extremely common, especially if there's a great deal of access, for someone to initiate tobacco use, especially on breaks as a means of socializing. Until very recently, there was a high level of access to low-cost tobacco products on military bases, and I can talk about some of the advances we've made in that regard. But this was another problem, and I've actually heard anecdotes of veterans telling me that probably pre-2014 or so, over in deployment zones, service members would have access to free tobacco products. So manufacturers would bring, for example, free chewing tobacco and distribute it. Thankfully, I've heard those practices have since been eliminated, but it did unfortunately lead to some tobacco use disorder in the cohort of military that served at that time. As people have commented in the questions, there is historically and even into today, there's a permissive military culture toward tobacco use. So sometimes the attitude is if one is in a life or death situation, that may as well smoke, or smoke them if you got them, and we can talk further about that as well. But that's a hard thing to overcome, and I think there are specific cultural aspects even within branches of the military. As I said, the Marines are the highest risk, and if one's peers are smoking, it places one at higher risk of initiation of products as well. So Marines and Army are at higher risk, and this to some degree stands to reason if you think about the stress of being deployed to a war zone and some of the duties that people are tasked with, and the breaks, etc. So And this has been verified by data, so we know now that deployment to the war zone is associated with elevated risk of smoking initiation, maintenance, and relapse. And that's even beyond, that's even outside of the context of somebody having a co-occurring mental health condition. If one is deployed to the war zone and they also have a mental health condition, that risk gets much higher. So as I mentioned, this smoke 'em if you got 'em is a historical uh, kind of phrase that has been used regularly, unfortunately. Tobacco has been generally used in the combat zone to relieve stress, and also for boredom relief, anger management. These are data from some qualitative studies in which post 9/11 veterans reported that they use tobacco for these reasons, to stay alert, socialize, and also to manage stress. One concern that it's also worth mentioning is that there may be some additive effects of tobacco use or smoking with exposure to burn pit smoke and air pollutants in some of the combat zones, such as in Afghanistan or Iraq. And these are data from the Vietnam Twin study that shows specifically that there is an elevated risk of tobacco use disorder that's bidirectional for tobacco use and PTSD. So tobacco use disorder is a risk factor for later PTSD development. And conversely, PTSD is a risk factor for tobacco use disorder. So they work in this, what I call a vicious cycle, and other investigators have called it as well, a vicious cycle of use of tobacco leading to, management of PTSD and other symptomatology, which then leads to further craving and use. So speaking of which, smokers with PTSD are at greater risk of lapsing within the first week of quitting and reporting more severe nicotine withdrawal. So this is important when you think about working with patients that individuals with PTSD specifically may have elevated anxiety sensitivity. They may be more acutely aware of the dysphoric effects associated with nicotine withdrawal and may be more likely to use tobacco products as a means of self-medicating. Symptoms of PTSD themselves, such as negative affect, hyperarousal, and anxiety sensitivity, can disrupt quit attempts. And I want to stress that this relief that's provided by the tobacco use is very temporary. So when I mention self-medication, it's something that doesn't in a meaningful and lasting way alleviate PTSD symptoms. It just temporarily can provide relief from anxiety and nicotine withdrawal. But in fact, this vicious cycle continues so long as the person uses tobacco. And there's a belief that's also somewhat historical that because people have relief with using tobacco, that we should therefore let them smoke because they're getting some relief. But that's not borne out in the literature. So people with PTSD, when they are successful in quitting, do not have worsening of PTSD symptoms long term. So these are just very temporary effects. So I mentioned the young combat veterans because they are at particularly elevated risk. This one study observed, kind of pooled several different results from different studies and found that there were epidemic smoking rates in the post 9/11, what we describe as the Operation Enduring Freedom, Operation Iraqi Freedom, Operation New Dawn, and I'm not familiar with some of the more recent conflicts, but some of the veterans that served since 9/11 have been at especially high risk of developing a tobacco use disorder, between 36 and 48%. Now, if you compare that with the prevalence of smoking that I mentioned in the general population, 15.1%, that's a striking difference. Some other things that we've been aware of for these young veterans is that 1/3 of them are residents of rural areas, and there's been increased attention to the need to make sure that there's outreach to rural communities because veterans in rural areas are less likely to receive smoking cessation services. They're also at higher risk of treatment dropout, not only from tobacco use treatment, but just generally. There is a challenge in engaging young adult veterans in mental health care and in traditional treatment. That's been shown in the PTSD literature as well. And in qualitative research, young adult veterans have reported that they prefer convenient, personalized services. So we are really striving within the VA to try to meet veterans where they are and respond to that need to provide flexible services, because a lot of these veterans are also managing school, work, family, and other responsibilities, which are especially critical when one is a young adult and trying to establish themselves financially, etc. So this is an overview of VA tobacco cessation services. So one glimmer of hope that I'll share is that veterans who are in the Veterans Health Administration have lower prevalence of cigarette use than those who have not accessed care through the VA. And I think it is because the VA has established best practices and gold standard treatment. Simply because the prevalence is so great in our community of veterans, and we have to be responsive to that. So we have a number of initiatives within the VA. First off, as many of you are probably aware, there is treatment provided within the primary care clinics. Usually that involves prescription of an evidence-based smoking cessation medication, including nicotine replacement, Wellbutrin or Chantix, as well as some brief counseling if available. In addition, smoking cessation clinic treatment is available in all VAs. So that is another service that is available at every VA hospital. I will say that is probably not available at every outpatient small clinic. So again, the rural veterans may be working with their primary care provider rather than the specialty program. But all veterans have access to this service if they're able to make avail of it. So. And then there's also the option of receiving assistance and counseling by a mental health professional who's part of the primary care team. That increasingly there's been an emphasis on providing behavioral health services within primary care. Several other initiatives that have been trialed within the VA. There's telehealth, which is increasing every year. There's improved technology every year, and therefore we can go even further in terms of trying to meet veterans where they are and reach them in their homes if we can. And then there are several other specialty clinics. So one thing I want to comment on is this integrated care. So integrated care is a model that was piloted by Miles McFall and Andy Saxon at the Seattle VA. I think maybe Puget Sound, I'm not sure, but was piloted by McFall and Saxon to examine whether or not one could deliver smoking cessation services within PTSD clinics rather than sending someone to a separate clinic. And what Doctors McFall and Saxon found was that delivering smoking cessation care within the mental health clinic that was providing the PTSD care doubled quit rates actually relative to the gold standard, which was smoking cessation clinic, which is actually quite good. So this was an exciting finding in that integrating smoking cessation treatment into mental health treatment has substantial benefits. And so the challenge becomes how to operationalize this and how to make this scalable, because as we all know, mental health providers are very busy, but increasingly we want this to be a priority for mental health providers because they're uniquely positioned to help patients quit because they have so much access to their patients and they tend to develop good relationships with them. Other resources that are free and available that you should all be aware of, the American Cancer Society and the VA collaborated to develop um, the Veterans Quit Line. Here's the numbers here. Basically, this provides evidence-based behavioral coaching in a proactive manner. So the veteran calls the quit line first, and then there are up to four proactive sessions. So that basically the quit line will then call the veteran back and on a weekly basis prepare them for their quit date, develop strategies, and help them to their quit date. So this is a free resource that you can share with veterans you're working with. There's also mobile health resources. So several Cochrane reviews at this point have shown that mobile messaging specifically, so text messaging services alone, have been associated with positive quit rates at 6 months. So this is an easy thing and a free of cost thing in some cases to maybe aside from the actual if someone has a mobile plan that charges them per message, it may not be free, but otherwise very low cost intervention in which people can receive text messages to support their quitting. And along the same lines, the VA has developed a mobile app called Stay Quit Coach to allow veterans to have access to evidence-based smoking cessation behavioral skills at any time. So the mobile health resources probably should not be viewed as a standalone treatment, but I think they can be a really important and meaningful complement to medication and to behavioral coaching as well. So this is one more tool to provide to your veterans, especially, as I mentioned, some of the younger veterans who may not be accessing care, but really to any veteran. And for a full list of resources, the URL provided here can be useful to you. So given the fact that there is an ongoing need within the DoD, we reviewed the literature regarding the rates of smoking within active duty. The Department of Defense is also making efforts. So in 2016, the leadership within the DoD at that time, Ash Carter, issued a memorandum stating there was a goal to have tobacco-free installations by 2020. So I appreciate the ambitiousness and also the urgency of that goal. And I think it is true that there are a lot of cultural barriers that one might think, oh, how could that possibly happen? But I think that they've made meaningful gains within the DoD. I work in the VA, which is a separate group, but the Department of Defense addresses and works with active duty and all active military personnel as opposed to retired, namely veterans. So in that memorandum in 2016, it was addressed that tobacco prices were going to be made commensurate with prices in the community, because what was happening is that military could use their military ID to go and buy tobacco products on military base at a fraction of the cost. They didn't have any of the taxes or other costs that were, for example, in New York or California or other areas. So there would be a higher likelihood that one could develop a tobacco use disorder. So I think that substantial gains have been made. Other things that you all should be aware of is that TRICARE, which is the insurance that the DoD offers for active duty, does also provide behavioral and evidence-based medication for active duty military if they are enrolled in TRICARE. And there are also tobacco control programs on DoD sites. So and this is increasing over time. But there are a number of challenges that still persist that we really continue to need to have to address. One is the minimum smoking age. So because the minimum age is now 21, this has created something of a health disparity in military, because the minimum smoking age for service members has been age 18. So it's been kind of a state by state thing to try to see if each state can match the age 21 minimum age. Because if you think about it, if somebody initiates tobacco use at age 18 and they can purchase their own products, that's a 3-year difference in terms of very formative and important years, at which point one may become tobacco dependent. And then the other thing to think about is that during deployment, as I mentioned, that's a really high risk period, and there are generally not a lot of resources available to help people quit smoking during deployment. So that remains a very high risk period. And the access, at least until very recently, has been easy to gain access to tobacco products. And like I said, since the issuance of that memo in 2018 by Ash Carter, there have been efforts made to address some of these issues around access, but they're not there yet in terms of eradicating those risks. So just to summarize, I think overall we have made great gains both in the civilian community and in the veteran community in terms of promoting cessation. However, there are meaningful and important differences that persist, particularly for at-risk groups, and I outlined some of those high-risk groups, namely young adults, individuals with mental health conditions, individuals with socioeconomic disparities, and several other risk factors. So I think it's going to be really critical, first of all, to try to target that period of initiation within the DoD when people first start using tobacco. That's going to be an important target for policymakers and for clinicians within the DoD. And then also within the VA, we want to try to expand services to veterans outside the VA, because as we learned from the CDC data, uninsured veterans are at much higher risk of using tobacco. So it may be a matter that a substantial number of people don't realize that they're eligible for VA benefits. And if we could allow those people to access VA services, perhaps they would have the access to facilitate quitting. And as I mentioned too, optimizing and personalizing technology-based treatments is always a good future direction, whether it be through telehealth, text messaging, mobile apps, and continuing to identify and outreach to these high-risk populations. And finally, I think it's really important to continue to collaborate with community partners who are caring for military and veterans to make them aware of the resources that exist for this population, and to think about the unique needs of the population. So I believe that is the end of the slide set.
Okay, wonderful. Thank you very much, Dr. Earps. So now we will move to question and answer. And as indicated at the beginning of the webinar presentation and requested resources are available for download. You are free to submit your questions in the presenter Q&A pod, and we will be taking questions that you've submitted from registration. Question 1, Dr. Earps. As a state health department in a state where there are multiple military bases, can you please make a suggestion as to how a person working at a state health department can make contact with the tobacco cessation staff on the military bases for collaboration and sharing of resources?
That is an excellent question. So I must say that because my work is localized within the VA, so I didn't introduce myself at the beginning, but I've been working at the VA San Francisco for 12 years, and my work is with veterans primarily. So I I don't have contacts within the tobacco control programs within the DoD. However, I think it is worth saying that this has become a high priority for the DoD. So I think that these programs do now exist, and this discussion has been on the table for some time now. I think 2016 was when that memo was issued by leadership within DoD. So in terms of outreach, I can try to research and share with the South Carolina Tobacco Free Group some of the potential resources that in order to get you connected. But I think it is really worth pursuing that at this time, because I do think it's increasingly a hopeful picture. So this is, in the past, I'd say even 10 years ago, it wasn't even being discussed to the degree it is now. So I will certainly try to follow up on that.
Thank you. Marcelina writes, I've heard that VA offers pharmacist-managed cessation services in which the veteran receives medication/NRTs and counseling from a pharmacist. Is this available nationwide, or is this specific to California?
So as I mentioned, there is a little bit of variance within each VA about which providers. So for example, as I mentioned, that the smoking cessation clinics within the VA exist nationwide. So every VA hospital is required to have a smoking cessation clinic. And within that, I think there is probably a range of staffing. Some smoking cessation clinics are staffed by mental health providers, some are staffed by nurses. Others have a pharmacist. But I think that in general, if you're talking about a major medical center within the VA, that research should exist. In at least is my understanding that it probably exists. If we're talking about a small VA clinic, it may not exist. But I would certainly call your local VA and inquire about the smoking cessation clinic and pharmacy. But we do here have an academic detailer within pharmacy at the San Francisco VA who can provide some limited services. But for example, in our VA, it's really the nurses and nurse practitioners who are delivering the smoking cessation services. So there's probably a little variance depending. But as long as there's a qualified clinician delivering that behavioral coaching, there is some standardization in terms of what's being offered.
Thank you. Yolanda asks, do VA medical facilities still provide designated smoking areas? And if so, why?
That's also an excellent question. So I actually have been serving on the Smoking Cessation Committee. And yes, the answer is yes, that these designated smoking areas are really kind of a vestige of the past that those of us within the field of tobacco control really very much would like to dispense with, but sometimes there are competing kind of forces of inertia with it that exist even within the VA. So there is a memorandum that was issued several years ago within the VA that required that any designated area be within or be at least 20 feet or something from the VA hospital. But that probably doesn't go far enough. And so here at our VA, we are currently making moves to really reduce. We currently have 3 designated areas, and as far as I'm concerned, that's 3 too many. But we want to try to especially work on the one at the nursing home and the other one over by the emergency room. So it really is a matter of, even though the VA has issued memoranda to try to minimize this risk, there is a certain amount of local control that's exerted. So if there are people that disagree with the policy, it can cause delays, but I think that we are moving in that direction as a larger VA. I think that that will happen. It's just that it's taking some time.
Thank you. Our next question, and I recognize this may be a bit of a leading question, so we ask for your opinion and your professional expertise in answering this question, Dr. Erbs. Why is there no one consistent voice against or position against tobacco use across all branches of the military? So why is there no one consistent voice or position against tobacco use across all branches of the military?
So thank you for the question. So I think I guess I would say that at the highest leadership level in 2016, the leadership within the Department of Defense, the military, did issue a memorandum very strongly condemning tobacco use. And so I think the challenge becomes, how do you operationalize that? How do you get that into, the culture of each branch? And so I think this is an ongoing issue that pertains to these aspects of military culture that take time to kind of undo myths, I think. For example, like that myth that if we're talking about, for example, like deployed Marines, this idea of smoke them if you got them, like that's an idea that takes some time to dispense with. And if you're dealing with there's a big difference between dealing with someone on a military base who may have access to tobacco control programs, or they may have a smoke-free campus, for example, and then you deploy that person to Afghanistan. They're going to have a lot more access to tobacco use, and their command may be different. So I think a lot of it, I still think that the highest risk pertains to the actual deployment to combat zones. I think that's a high risk that we haven't fully figured out how to address yet, other than prevention and really early intervention is a goal of many in the field.
Thank you. Our next question, and I'm going to paraphrase Mary's question. Essentially, she would like to know if a veteran or active duty personnel member is also presenting with a mental health challenge, is it possible for their medications, the medication that they would be receiving to treat their mental health challenge, is it possible for there to be an adverse drug interaction with any prescribed medications to control their tobacco use?
So that is always a challenge, but I will say that actually smoking itself affects medication levels of several psychotropic medications. So there's the cytochrome P450 system is the liver metabolic system that metabolizes our various drugs, and the cytochrome P450 enzyme 1A2 is induced by tobacco smoke. So because basically tobacco smoke revs up that enzyme, and so it essentially decreases the effective levels of a number of different psychiatric drugs. So it decreases levels, so smoking decreases levels of caffeine, haloperidol, clozapine, methadone, olanzapine, tricyclics, a number of other psychotropic meds. So you could think about the smoking as actually really chewing up somebody's medications, and so there's that drug interaction right there. Those of us who are skilled at working with co-occurring conditions are really careful. So the three evidence-based medications that we use are nicotine replacement, and combination is superior to single agent. So for example, a patch plus gum or lozenge, that's very effective. Wellbutrin or bupropion is also effective, and Chantix. So there are unique considerations with each. So with respect to the bupropion, bupropion is an antidepressant, so sometimes that can be beneficial for a patient if they are also depressed. They could consider taking bupropion to quit smoking, and also may address their depression at the same time. However, bupropion is known to potentially contribute to symptoms of anxiety or insomnia in some people, not everyone. So that's we try to do some treatment matching. So if the patient may have high levels of anxiety, we may use caution with bupropion. In terms of Chantix, varenicline, there was a great deal of concern when Chantix first came out about the risk of behavioral disturbances and suicidal thinking. And actually, the FDA has since removed the black box warning. I believe they removed it at the end of 2017. So varenicline is now increasingly being used. And so we use caution with it, of course, and we follow the treatment guidelines. But I don't think that the risks are as substantial as once believed. But that said, you have to monitor someone. So we're always thoughtful about these potential drug-drug interactions. But I think I think of the tobacco use as a far greater risk long-term. Usually most patients can tolerate nicotine replacement. There's rare exceptions, maybe pregnancy or somebody with a severe cardiac condition.
Thank you. Our next question. Can you please speak to some of the best practices associated with providing behavioral counseling and or tobacco cessation counseling to rural veterans? Specifically, they're asking for interventions aside from the quit line and or telehealth interventions due to potential connectivity associated with telehealth, but can you also speak to some of the benefits of using a telemedicine intervention strategy?
Yeah. So behavioral therapy does have a great deal of evidence behind it for tobacco use disorder. What we know about for example, like the gold standard of treatment would likely be a behavioral therapy of at least 4 sessions with some kind of medication that's evidence-based. So one of the meds we just described, the nicotine replacement, bupropion, or varenicline plus behavioral therapy is probably the best treatment we could offer. Behavioral therapy tends to target learning processes and contextual factors that are associated with triggers and managing triggers and craving, finding ways to reduce withdrawal, and engage in social support. So those practices are evidence-based, and the good news is that I think that the VA Quit line uses a lot of those resources. So they do use a lot of those skills, the behavioral therapy skills that have been found to be efficacious. So I think in the Quit line, one would work towards setting a quit date and identify triggers in their environment and work to reduce those, develop a coping plan using the AARM model. I think that's advise, assist, replace, and mentally cope. That's part of the U.S. Preventive Task Force recommendations. So the Quit line is a useful behavioral intervention, but it is worth saying that that veterans in rural areas, aside from the Quit line, probably don't have access to the degree of services that those in urban areas do, through the smoking cessation clinic, and that is a disparity. So I think the direction the field is moving is trying to identify novel ways of providing the same degree of high quality services into rural areas. And I think the telehealth interventions are really promising. I heard recently about video on demand, so video visits, in which you could kind of deliver the same degree of high quality service, but they would be available via video visit downloaded to the veteran's phone. Now, of course, that always comes with the caveat that there's Wi-Fi connectivity issues in rural areas. So not all of those things are going to be available, but I think this is a really important direction for the field for addictive disorders, and making sure that we provide services to those rural areas. So I think it's an area of active inquiry. We are currently looking at a telephone-based intervention for a project funded by the Tobacco-Related Disease Research Program, a tobacco intervention that's designed specifically for veteran smokers with PTSD, in which we're going to be using technology as well. So there are a number of investigators trying to look at how we can establish some parity for rural veterans.
Thank you. And Dr. Earps, you've done a wonderful job of providing an overview of evidence-based and efficacious interventions. But from your research, have you found any gaps in the provision of cessation services for military personnel and veterans?
So yes, absolutely. So I think that kind of along the lines of what the last provider question was, I think if veterans cannot come to the VA, if they have travel barriers or if there's geographic barriers, sometimes women veterans who have competing child care responsibility, and obviously male veterans as well, but sometimes women veterans are juggling multiple different roles. And if they can't make it in for the office visits, that can be a challenge. And so I think that that's an area that we're trying to actively address. And I think that for the young veterans, there's still a little bit of a stigma associated with help seeking. And so that's why we're trying to increasingly outreach to communities and try to meet people where they are, because it's hard if someone is not used to seeking care. And I think in military culture, there's sometimes an element of help seeking being associated with weakness. So kind of trying to dispel some of that as people, acculturate to civilian life post-deployment, and trying to help people gain some trust with healthcare providers and coming in for help. Those are some things we're working on. And like I said, I think what is kind of a common thread is in the smoking cessation field is that there are just these at-risk groups. So even though we're making great gains in the larger community, in every community, including the military and veteran community, there's going to be these high-risk groups. And so I think I encourage you to think about those groups, particularly those with mental health conditions, those who are impoverished, and or in rural areas. These are the people that we're most worried about.
Thank you. So we have one final question, and then I will ask you for your closing thoughts. Are you familiar with any mechanisms through which local or state health departments can partner with the VA to provide tobacco cessation services to their population, or inverse, if the state or local health department has an efficacious intervention that they can serve as service providers to military personnel through the VA? So, short question, are you familiar with any partnership opportunities, which may be grants available or funds available, or simply collaboration opportunities available?
Yeah, so I think that's highly necessary. And one of my colleagues is the liaison for for SAMHSA. She's the military liaison, Cecily McElwain Burrows, and I collaborate with her regularly to talk about how community partners can engage with the VA, because we do have a number of resources and we want to make sure those get to communities. I think in general, like I'm not a policymaker. I'm a researcher and clinician. So, but I do think what I've found very encouraging is that there is a strong desire for these partnerships to be forged. So, for example, locally we have a student veteran health program at our community college where we partner with the City College of San Francisco, and we have a VA clinic where we offer VA services right on campus. And one of the services we offer is smoking cessation. So I've been surprised at how open various agencies have been, and I think it is worth really actively pursuing and reaching out to leadership. But if anyone ever wants to pursue a collaboration, or if they want to get advice, they're welcome to email me. I can share my email with the organizers. and I could try to point people in the right direction.
Thank you so much. And finally, we will close with your closing thoughts.
Great. So I really appreciate the opportunity to talk with this group of interested parties regarding the health of military and veterans. I think we have made substantial gains, especially data are quite promising for veterans who engage in VA healthcare and access the services that we have. But there's still a long way to go, particularly for groups that face health disparities. So our new goal and our continued goal is to try to promote cessation for the highest risk groups, as I've outlined. And I think the other goal is to partner in the community and make sure that our services are disseminated in the VA.
Dr. Earps, thank you for an extremely informative and highly engaging presentation. And I thank each of our each of our attendees for attending today's webinar. Again, the webinar presentation was recorded and will be made available within 48 hours via email. And the resources which were shared today will also be made available on the South Carolina Tobacco Free Collaborative website. Thank you, and I hope you each have a wonderful afternoon.